So welcome to this symposium titled the contribution of neurophysiology to migraine, from basic mechanisms to the effects of novel treatments. I am Massimiliano Valeriani, and I'm honored to be president of the Italian Society of Psychophysiology and Cognitive Neurosciences, which is endorsing this symposium. You know that the society is affiliated to IOP. So migraine represents a very interesting model for the neurophysiologist, for the psychophysiologist, since there is the possibility to investigate something which does not work so well, but which does not show any evident lesion, structural lesion. So we will have some speakers who are, I can say, among the most important international speakers, researchers on these subjects. The first speaker will be Professor Filippo Brighina, who studied a lot the cross-modal perception as a tool to investigate the cortical excitability. The second speaker will be Professor Marina De Tommaso. The third speaker, Gianluca Coppola. Both of them will face the mechanism of action of anti-GRP antibodies. You know that this drug is revolutioning the treatment of migraine. And finally, I will show you some results we got in children with migraine. I don't want to waste more time. Thus, I'm going to introduce the first speaker, Professor Filippo Brighina. Please, Filippo.
Okay. You see the slide?
Yes, perfectly.
Okay. First of all, please, this is the last one, sorry. Okay. First of all, please let me thank Professor Valeriani for the invitation to this interesting symposium. As he said, I will speak about core changes of cortical excitability as explored by the technique of sound-induced flash illusions in patients treated with the anti-GRP antibodies, migraine patients treated with such drugs. This is disclosure. This is an outline of the presentation. Just some notion about migraine pathophysiology, the role of cortical excitability, and the relevance of the migraine ground, as we know. And then moving to this technique that we used particularly in the last years, studying excitability in migraine, that is sound-induced solution, that is a technique based on cross-modal perception that showed to be really reliable to explore, evaluate cortical excitability in migraine. The other point that take us to the principal aim of the study that I present is that concerning the possible plastic modulatory interaction between peripheral and central targets, and how this can become relevant for treatment, for evaluating treatment. And then the results of the study that showed some evidence, even if preliminary, about a potential bottom-up effect of these drugs on cortical stability. Well, understanding migraine certainly would mean understanding the attack, but also and principally perhaps the predisposition to attack. The attack mean aura and headache. Aura, as we know, is due but to a phenomenon known as cortical spring depression. That is a wave of hyperpolarization followed by depolarization, followed by hyperpolarization that move slowly across cortex, and while the headache is followed to activation of the trigeminal vascular system. These are clear milestones of our understanding about attack. On this based also the evolution of new treatment. I refer to the trigeminal vascular system and in particular CGRP. And the other point, perhaps the most important one, is that of predisposition to attack. What we know about that? We have relevant insight about that coming by studies in experimental models of in animals looking for genes of family hemiplegic migraines that are known to alter function of neural membranes, eating calcium channels, potassium, sodium pump, and sodium channel. All these abnormalities have as a final effect an increase in glutamatergic transmission. And this points both that of increase in excitability and based changes in glutamatergic neurotransmission have been clearly demonstrated in studies in experimental animals. But evidence about changes in glutamate concentration are also available in humans. This is a study of some years ago using magnetic resonance spectroscopy that clearly shown increased concentration of glutamate in patients affected by migraine inhibitory. And the other studies more indirect evidence based on a particular visual, a particular cognitive function that is visual spatial learning, explored the supraspan condition that is linked clearly to glutamatergic neurotransmission that we show to function better in migraine patients with respect to controls. But another point that we have to discuss is that evaluation of cortical excitability. Cortical excitability has been evaluated in migraine with several techniques. Techniques like neurostimulation, in particular transcranial magnetic stimulation, a transcranial electric stimulation technique, have been diffusely employed and showed to us interesting points concerning the pathophysiology of migraine, and with particular reference to cortical activation in migraine. However, this technique, particularly rTMS, induce also paradoxical inhibitory response, particularly when they are used at high frequency, and particularly in patients where high excitability states, like in chronic migraines, are well documented and agreed by researchers. These unwanted responses can disturb also interpretation of finding obtained this way. So in last years, we moved to another technique that seems to be more reliable and also with more clear result. Here we show you a paradoxical effect of inhibitory effect of rTMS in chronic patients that should have a condition of increased excitability. And so in this patient, we expect we should expect a potentiation like that observed, having higher potentiation with respect to that observed in normal control that is represented by this line. Instead, we observe a clearly inhibitory effect. Sound use resolution gave us the opportunity to overcome this problem. But what exactly means, what exactly is sound use resolution? It is a technique where patients are presented with visual flashes and here also auditory stimuli, beeps, and then have to report the number of flash seen. It is important to say that auditory stimuli precede by a few milliseconds visual ones. We have two different conditions. When one flash is presented with two beep, the subject is tend to report more flash than those seen, and so she tend to say two flashes seen. This is the fission illusions. Differently, when two flash are presented with one beep, subject report one flash. That is the fusion illusion. We simply can say that in this condition, visual perception is driven by the auditory one, and these are therefore named the visual illusion induced by sound. This is an example. It works. It's a similar condition, not the same, but just to represent the technique. You you saw the flash, you see flashes and beeps, and at the end of the presentation, with single presentation, the patients had to report the flash seen. But why to study this technique for explore visual cortical excitability? That is because in a seminal study in 2011, Bolognini showed that these illusory perceptions are critically modulated by excitability of visual cortex. And indeed, increasing the ability of visual cortex authors observed a clear reduction of illusory phenomena. On such a basis, we explored this some years ago this technique in migraine patients with the hypothesis that in a condition of increased excitability, a patient should report less flashes with respect to less illusion with respect to control, and this indeed occurred. You can see here the curve of flash reported. The curve increases, of course, when increase the number of flash presented with increases the number of beep presented together with single flash, and you see here that LT control perceive more flash than patients. So patients have a greater cortical excitability, and there is a gradient in this excitability as the higher level is that observed during the attack. These are patients studied during attack. Patients studied with the patient affected with aura studied during attack have the higher excitability level. That means in this case the lower percentage, the lower number of perceived flash, lower illusions, lowest illusion during the test. We showed the same also in patients with chronic migraine. We observed here a greater reduction with respect to normal as concerns perceived flash. That means a greater excitability levels. And when putting together this result, we show a clear gradient that goes from the normal control that perceive the higher number of flashes to episodic migraine seen interictally, ictally, and then chronic migraine, and patients abusing triptan that are those that perceive less flash than the others. And so there is a relationship with the also with the severity of the condition in which the test is done. The excitability is greater during the after. It reaches top in chronic migraine and in triptan abuser. The other point that is the point of our presentation is that of relationship between peripheral and central level in mechanism in migraine. Peripheral trigeminal structure and trigeminal vascular system and central cortical of subcortical areas are in some way connected in migraine. Do exist plastic interaction between the two? If so, drug affecting one of these two levels can indirectly induce changes in the other through respectively top-down or inversely bottom-up mechanism. Could this be important also when evaluating global effect of drugs and their ability to induce persistent plastic modulation that could be regarded, and this is a particularly important point, as a disease-modifying ability. So we had a good tool to explore stability. We found also a good condition to explore potential bottom-up mechanism, that is to evaluate cortical stability in patients that are treated with monoclonal antibodies anti-GRP that are known to exert its effect at peripheral level, as they don't cross blood-brain barrier. So exactly what we did, what we did, and we studied 66 patients. The majority of them were treated with Erenumab, 30 patients, 20 with flemanezumab, 16 with galganezumab. Data concerning patients are briefly reported in this slide. The results were compared, neurophysiological results for some user efficiency were compared with 30 healthy subjects in the same age and sex range. As methods for exploring sign user resolution, I have already presented it, these methods. Patients were presented with different, several combinations of flash and beeps, and each combination was repeated 9 times. All comparison were performed by Minova with Duncan test for post-hoc. Patients, we explored also clinical measure, migraine days per month, medicine consumption per month, and MIDAS score. SIFI clinical parameters were planned to be recorded at the time at baseline and every 3 months till 1 year of treatment. However, it is to say that differently for our expectancy, we were not able to recruit a good number of patients to explore till 1 year of treatment, and to stop to 6 months T2 time. Here you can see the results about clinical parameters. As you can see, and this is known by already reported strong evidence about efficacy of this drug, and you can see clearly as this parameter changes both for migraine days, for medicine consumption, and also for a measure of disability. And now move to the most important point of the study, that is the effect on SIFI. As you can see, the first line, the higher line in the graph, is that representing normal control. This is the group that perceive more flashes than the other. The other line concerns the same group of patients explored at different times. The gray line, sorry, it's better to start from the blue line that represents the baseline time, then the orange line that represents the T1 time at the distance of 3 months, and the gray line that represents the T2 time at the distance of 6 months from the starting. And what you can see, of course, is that the yellow line is significantly different from the other lines, and this is known as chronic migraine show very high cortical excitability with respect to control. But the most important point for this study is what happened at the 3 lines of patients, the different times. As you can see, there is a slow but evident change in cortical excitability in the sense of the reduction of cortical excitability, moving from T0 from T2, and the difference become significant at T2. So, in conclusion, SIFI confirmed to be a cheap, well-tolerated, and effective tool to explore cortical excitability and these changes in migraine, if also in these patients under treatment with anti-GRP. CM patients show an increased visual cortical excitability as compared to control, as showed, confirming evidence reported previously. Sorry for my phone. Anti-GRP treatment induced also an appreciable and significant but late change, reduction, increase in visual cortical, reduction in visual cortical excitability at T2 after 6 months of treatment. This change occurred so long after the starting of clinical effects that are clear and consistent already at T1 time and are known to occur as early as the first month or also the first weeks of treatment. This, however, could be due to longer time needed to induce plastic indirect effect. If this changes, we can see a conclusion that if this conclusion that if these changes will show to be lasting after stopping treatment and paralleled by clinical ones, its potential role as marker of disease modifying effect would be certainly worth to explore. To conclude, I wish to thank my group and also to thank Professor Vallar and Bolognini that cooperate with our group for this study. They are international experts about sound flash illusion. Thank you.
Thank you, Filippo, for the very interesting results. If something happens at the periphery, it can influence the brain too. So let's move to the second speaker, Marina Tommaso, who I can imagine will speak of pain, of nociceptive evoked responses, isn't it?
So good morning to everybody. Now I want to talk about these new treatments about CGRP monoclonal antibodies on central processing of pain in migraine. This is a very famous image about pathophysiology of migraine, where you can understand very well that migraine is a central nervous system disorder. And in fact, we have a high susceptibility to external triggers and altered excitability of cortex, and then the activation of trigeminovascular system. And so here are main characteristics of migraine without aura and with aura. And you know very well that in the case of aura, we have focal symptoms preceding migraine. That migraine headache is very intensive and disabling. Also the problem is chronic migraine, where we have 15 days or also more with this problem, and the life of patients is very affected. In fact, migraine is recognized as the second disability cause among neurological disorders. But what we are now observing is that we have a new era in migraine, because now we have new drugs, but these drugs act in the periphery. And so we want to understand if in the long-term situation, we could have a modification of disease. So if these treatments are disease modifying. Consider that the involvement of central nervous system is very clear in migraine. In fact, altered excitability of cortex and also thalamocortical dysrhythmia led to cortical spreading depression, which is a phenomenon spreading from the posterior regions to the anterior ones. And during this potassium extra production, and we have the activation of C fibers in the meningeal and perivascular sites. It is well known from animal studies, and so we have to understand how this cortical spreading depression could be generated, first of all, and then also how this trigeminovascular system is activated, and how it can lead to persistence of pain through migraine, chronic migraine. The new drugs just act on C fibers, on A-delta fibers, and in the periphery. But real migraine is a central nervous system disorder, and we have many evidence. Our group have demonstrated in the last 20 years that, for example, migraine is an oscillopathy. And so we have altered synchronization of rhythms, alpha, first of all, under visual stimuli. And we have also different oscillation patterns between migraine without aura and with aura. Just studying pain, we use laser-evoked potentials, which are generated from the main cortical regions, which are devoted to pain processing. And they are opercular insular regions and the anterior cingulate. And here you can see the main waves that are generated, the N1 from the temporal regions, the N2P2, which is mainly generated from the insula, and the T2 from the anterior cingulate. We have studied in the last 20 years laser-evoked potentials in migraine and how pain is processed. It is very interesting because it is a psychophysiological model. In the last years, in fact, we have also observed, and other groups have just discovered, that the laser-evoked potential model is a model of response to relevant salient stimuli, and that the same cortical regions could be activated by tactile or auditory on visual stimuli pending their relevance. Pain is relevant for definition, so these types of studies contributed to accept the concept of science matrix more than nociceptive or pain matrix. And it is very important because the way in which patients consider relevant pain could alter and change just the activation of this science network. One of the characteristics of migraine patients is a reduced habituation to repetitive stimuli, and this also at times laser evoked potentials. And in fact, while in healthy subjects, the laser evoked potentials goes into a loss of relevance progressively with repetitive stimulation. This is not in migraine, so they consider the painful stimulus always very salient, and so the response of these cortical generators, and first of all anterior cingulate, is always very strong. We also have traduced and translated this phenomenon into connectivity patterns. And some years ago, we also observed, for example, that when we deliver a painful stimuli to patients, migraine patients, we have effective connectivity pattern regarding the transfer of information from the opercular insular regions to the anterior cingulate. This is very strong in migraine. So the connectivity pattern, effective connectivity pattern in migraine is different from non-migraine subjects. And the persistence of very busy information transfer in migraine patients along repetitive stimulation is the counterpart of reduced habituation. So while in normal subjects we have a progressive synchronization, and so a loss of transfer information from the opercular insular regions and the anterior cingulate, this does not happen in migraine. And so this is the connectivity pattern corresponding to reduced habituation to repetitive painful stimuli. We also translated this concept with models with the dynamic causal modeling. And just during repetitive stimulation, we observed last year that the connection between the insula and the thalamus and the insula is increased in migraine in comparison with non-migraine healthy subjects. So we have now the CGRP antibodies, and they act with success in migraine, and their way of action is on DC fibers. So they could act on directly on the CGRP and on the CGRP receptors. And the cortical splitting depression activate the C fibers, and the C fibers produce, first of all, calcitonin gene-related peptide. And this calcitonin gene-related peptide is produced by C fibers, is then received by delta fibers and by vascular walls. So it is very clear that this central neuronal phenomenon as cortical splitting depression activate trigeminal C fibers in the periphery. Trigeminal C fibers produce CGRP. CGRP is just received by delta fibers, which are activated and just transport the painful signals from the periphery to the center, and it also activates the perivascular CGRP receptors. The effect on vascular walls is very clear, because when the CGRP is received from the CGRP receptors on the vascular walls, we have vasodilation. And after vasodilation, we have a production of other peptides of inflammation, as a substance P, histamine, and nitric oxide acid. And so the sterile inflammation is in the full, and the patients just feel intense headache. And so we have these types of new drugs. They could act directly. They are monoclonal antibodies. They could act directly against the CGRP or directly on the receptors. They do not pass the blood-brain barrier. They are very large molecular, and this is in fact an example of how the monoclonal antibodies are large in respect to the direct CGRP antagonist, and how they could not pass the blood-brain barrier. So they act in the periphery, and so they have a very clear effect in migraine. But what about long-term effect? Could they modify the central nervous system abnormalities which are present in migraine? All the groups which study about migraine have the same question. Could this oscillopathy, could this connectivity disease be modified under this peripheral influence? This is a very important question, because the destiny and the outcome of migraine must be changed, and we don't know really if these drugs could just have this very important effect. We have some evidence from animals. For example, fremanezumab, which is a directly CGRP antagonist, could slow propagation of cortical splitting depression in animals. So it could just have this effect. And probably if we slow cortical splitting depression, we could have a few number of C fibers activated. Studies about this question of the central effects of CGRP monoclonal antibodies are increasing in the last weeks. And for example, we have this fMRI study about the effects of erenumab 70 milligrams on functional magnetic resonance activation. And these authors just observed that, for example, responder patients have an reduction in hypothalamus activity. And some groups think that hypothalamus is the generator of migraine without aura. So this is a very important topic, a very important point. Some months ago, we conducted a pilot study about the effects of erenumab 70 milligram on laser-evoked potentials, and we have just a study design with a sham recording after a few hours after CGRP injection, and then a control after 15-20 days, which is the time in which the drugs could be active. And then in clinic control after 3 months, which was not just associated with neurophysiological study, just for COVID reasons. These are our 17 patients. They were responders. They were migraine without aura and chronic migraine, just drug resistant, resistant to other preventive treatment. And we observed a mild inhibition of this central, of these cortical responses evoked by laser, which was delivered at the face, so in the trigeminal place and on the hand back. And we observed a mild inhibition. Here are the statistical probability maps about the negative waves, the N1 and the N2. This was present only at the trigeminal levels. The inhibition was not present from the hand. So this could suggest to us that, first of all, in the skin, the CGRP is represented, and so it could be blocked. It is important because, for example, the pain in the skin is disabling in migraine. This is for allodynia phenomenon, and so this type of drugs could also act on the pain generated in the skin. The other important question is that the CGRP could inhibit those cortical generators which are activated by painful stimuli, and so they are the peripheral insular zones and the cingulate. Another important topic was that Renumab was able to restore reduced inhibition. So it has a central effect, at least on pain processing. And so they could change this important aspect and neurophysiological abnormality characterizing migraine. So how peripheral action of CGRP could prevent migraine? We have an hypothesis which also arises from one of our recent studies. In fact, we made a models of migraineur and cortical spreading depression progression on realistic MRI of patients, and we compared the effects of cortical spreading depression, which was generated on mathematical models, and we observed that on the cortex of these patients, cortical spreading depression was very large, and it reached also all the regions which generated painful, which processed painful stimuli. So in our idea is that if the drug is able to block these cortical regions, for example, the insula, the S2, the anterior cingulate, they are very large portion of cortex, and so if they are inhibited, they could slow the cortical spreading depression progression, and this is also in agreement with animal studies. So this is our hypothesis: the inhibition of cortical regions devoted to pain processing could exert a general modulation of cortical excitability and connectivity, and just cause an interference on cortical spreading depression progression. So this could explain not only the effect on headache intensity, but probably also the effect on migraine generation. The response will be present in future with the prosecution of these types of studies. So thank you very much for your attention.
Now, I will be the only speaker today not to speak of monoclonal antibodies. You can ask me why. So there is a simple reason, because I normally work with children, and these drugs are not have not licensed for children yet. Of course, there are clinical trials with the use of this drug in placebo in children, but they cannot be used in the clinical practice as with the adults. However, I hope to be able to show you some interesting data. What is the role of neurophysiology in pediatric age? The same the same role which neurophysiology can have also for others. Two possible important elements of neurophysiology. The first, the contribution to the knowledge about the pathophysiology of migraine. And the second point, the identification of markers important for differentiating migraine from other types of primary or secondary headaches. So I would like to show you here two papers. Two papers. One, the first is a review article published some years ago, and the second is a more recent chapter of a book I wrote together with Parisa Gazzerani from Aalborg University, and the editor was Gianluca Coppola. So showing the main results we have about the neurophysiological investigation of children with migraine. So today I would like to face 2 points. The first of which has been largely discussed by the other speakers, that is the cerebral cortex excitability. I will show you how this point can be studied also in children. And the second, which I think is very, very important, especially for pediatric ages, that is the interaction between the cerebral cortex excitability, which represent, we can say, the genetic background of the disease, and the psychological factors, which are definitely extremely important in pediatric age, surely as a triggering factor which can determine the severity of migraine, but also for other reasons, how we will see later. So this is an historical study which was the first to show what is the most important neurophysiological abnormality identified in patients with migraine. That is, as you have already heard several times today, the reduced habituation of the migrainous cortex. These authors, Martin Denordu and Jacques Chenin, use the contingent negative variation to demonstrate that migraine patients don't undergo the physiological habituation, unlike what happens in a patient with tension type headache. So the reduced habituation of the evoked potential was demonstrated using practically evoked potentials of all modalities, including also the nociceptive modality. And I show you here this study by Marina De Tommaso in children. The authors here recorded the laser evoked potential in children, thus studying in a selective manner the nociceptive system, because you know that the laser pulses activated the small myelinated A delta fibers without any concurrent stimulation of the large myelinated A beta fibers. In children with migraine, first of all, the laser evoked potential showed an higher amplitude as compared to non-migrainous children. And moreover, the phenomenon of habituation you see here evident to hand and face stimulation in healthy children was lost, was not present in children with the migraine. So the reduced habituation, what does it mean? It is an element suggesting that there is an abnormal excitability of the cerebral cortex. Probably an hyperresponsivity of the cerebral cortex to the afferent input. This hyperresponsivity can be demonstrated also by other techniques. Here, some years ago, we measured the recovery cycle of somatosensory evoked potential in children with migraine. What is the recovery cycle of an evoked potential? When brain responses, not only brain, nervous responses, so let's say, are recorded after stimulation with the two coupled stimuli, the response evoked by the later stimulus is reduced in amplitude as compared to the response evoked by a single stimulus. If this reduced amplitude is due to inhibitory processes involving probably also refractoriness of the membranes activated by the first stimulus. If the interstimulus interval, that is the time between the coupled stimuli is increased, is enlarged, the amplitude of the response evoked by the second stimulus tends to increase too, up to reach the same amplitude as that of the response evoked by a single stimulus. So this is what we recorded in a healthy child. We recorded SEPs from the periphery, from the brachial plexus. We stimulated the median nerve, from the cervical spinal cord, and from both the parietal and the frontal cortices. So you see, these are the responses evoked by a single stimulus, and in these other three cartoons, there are the responses evoked by the later stimulus in a condition of coupled stimuli with different interstimulus intervals, 5 milliseconds, 20 milliseconds, and 40 milliseconds. You see that the amplitude of the cervical response and of the cortical responses is dampened in the condition of coupled stimuli, and the definitive and so the initial amplitude is not reached even in the condition with the longest interstimulus interval, that is 40 milliseconds. This is what we recorded in a migraine child. Also in this case, when there are two coupled stimuli, there is a reduction in amplitude of the cervical and of the brain responses, but the reduction was lower than what we observed in healthy children. Possibly this point is clear in this graph. Sorry. Here the dotted line represents 100%. That is the amplitude of the responses recorded to a single stimulus. Instead, the columns represent the amplitudes in percentage of the responses recorded in a different interstimulus intervals, 5 milliseconds, 20 milliseconds, and 40 milliseconds. You see that in healthy children, the cervical response and all the cortical responses did not reach 100%, so did not recover completely their amplitudes, even in the condition with the longest interstimulus interval, 40 milliseconds. Different is the situation in migraine children, where instead at 40, but also at 20 milliseconds, the amplitude of the responses approaches that obtained after a single stimulus. What does it mean? This means that the recovery cycle of the somatosensory potential in children with migraine is shortened. And this can be attributed to a dysfunction of the inhibitory processes, but meaning also an hyperactivity of the cerebral cortex. We tested also this recovery cycle of somatosensory potentials in patients treated with a drug commonly used for migraine prophylaxis, that is topiramate. Topiramate is an antiepileptic drug considered very useful in migraine prophylaxis. We saw that in patients in whom topiramate had been effective to reduce the frequency of migraine attacks by at least 1/2, we found a prolongation of the recovery cycle of SCPs. You can see here that before treatment, so the cortical responses approaches the amplitude of the response to a single stimulus at 40 milliseconds, but for the N30, even at 5 milliseconds of the stimulus interval, you see that the columns are lowered after the successful treatment with topiramate, meaning that there is a reduction of a hyperresponsivity of the cerebral cortex with the drug. So all this data fit well with this pathophysiological theory, which was proposed for migraine in this review of some years ago, review including all the speakers of this symposium. You see that a key role in the pathophysiology of migraine should be played by an abnormal function of thalamus, the so-called thalamocortical dysrhythmia, leading to hyperresponsivity of the cerebral cortex, explain the reduced habituation, explain the shortening of the recovery cycle of hypopotential, and so on. So interestingly, I would like to show you how we use this technique, so the recovery cycle of SCPs, to investigate whether there could be some difference according to migraine phenotype. So we started in this case from this observation of the group of Rami Bernstein, according to which they identified patients with pain directed from outside to inside, so-called imploding pain, as responsive to injection of botulinum toxin A, and a patient with pain directed from inside to outside as non-responsive to this treatment. So we would like to see whether we could identify some differences between these two groups, and we recruited children with exploding pain and others with imploding pain, migraine's children, of course, and we recorded the SCP recovery cycle, and we showed that we show a weak difference between the two groups, but significant. So the recovery cycle of the N30 was shorter in patients with imploding pain as compared to those with exploding pain, showing that this patient had a higher excitability of the cerebral cortex as compared to patients with exploding pain. Interestingly, when we try to correlate this abnormal excitability, abnormal recovery cycle of the N30 response with a psychological measure, in particular hunger, we found an opposite correlation in patients with exploding pain who showed higher hunger with the higher cortical disexcitability as compared to patients with imploding pain, in whom hunger was lower when the cortical excitability was higher. So this give me the opportunity to introduce the next point I would like to discuss today, that is the relationship of the abnormal working of the cerebral cortex, the abnormal excitability of the cerebral cortex with the psychological factors. Some of our results showed that psychological elements in pediatric age are more than a triggering factor for migraine. Here, for instance, in this study, we recorded two well-known event-related responses, mismatch negativity and P300, two auditory stimuli. We recorded 3 trials, and we showed a physiological habituation in control subjects for both responses. The habituation was not present, or at least was reduced, not only for children with migraine, but also for children with tension type headache. And this is an important point because most abnormalities, neurophysiological abnormalities found in children with migraine can be found also in children with tension type headache. And this suggests that at least at this stage, migraine and tension type headache do not represent different, well separated entities, but they are probably two extremes of a continuum in which migraine represents the more severe part, and the tension type headache the weaker part. So not only we tried to correlate the abnormal habituation of the P300 with some psychological scores issued from this questionnaire, child behavior checklist, exploring different kinds of psychological level, especially the CBCL explores the internalizing disturbances, anxiety, depression, and externalizing ones such as anger, aggressiveness. And so we found in migraine children that those with the more abnormal excitability of the cerebral cortex were also with the worse psychological profile. What is interesting that this correlation was found only in migraine children, but not in healthy subjects and in children with tension type headache. Thus, this led us to suggest that in pediatric age, probably tension type headache and migraine share the same background of this excitability of the cerebral cortex. And what determines the development of migrainous phenotype is just this interaction between the genetic aspect of the disease and the psychological elements. We succeeded in confirming this point also in these other studies in which we used a more specific psychological tool, the SIFI score. Also in this case, we found that the abnormal habituation of the P300 potential showed a positive correlation with social anxiety with total anxiety scores. So I would like to finish with some recent results where we published not using neurophysiological methods, but using a brain MRI. These are, however, interesting because you know that there are a lot of studies showing structural changes of the brain in adults with migraine. But there are only few reports of this modification in children. I think that children are particularly important in this case because they have been less exposed to other factors which can occur during the life. Thus, finding some structural modification in children with migraine allow us to relate this modification directly to migraine without other possibly confounding factors. So we in particular explored in this study gyrification, which is a structural parameter which was rarely investigated in headache. And we found that patients, as compared to control, showed a lower gyrification in this parietal cortex area. And within patients, female showed a lower gyrification in these areas of the parietal and of the temporal lobe. This probably possibly correspond to the auditory cortex. As for cortical thickness, within patients, we found that The children older than 12 years had a lower cortical thickness in the peripheral-central region as compared to the youngest one. And also we found also a difference in the pars marginalis in patients showing nausea or vomiting as compared to those who did not have these symptoms. These are our conclusions. We underline that older patients, older than 12 years, show that decreased cortical thickness in areas related to executive function, and nociceptive networks, the so-called pain metrics, compared to younger patients. The reduced cortical thickness in female patients in the auditory, at the level of the auditory cortex, suggested that it could be important to explain the higher prevalence of phonophobia in our male patients. But so what is important, I think, in this study is that we succeeded in showing some brain some changes in the brain structures even in pediatric age, where really they can be difficultly attributed to other factors than migraine itself. So I'm going to conclude with these take-home messages. Neurophysiological studies can investigate cerebral cortex excitability also in migraine. The correlation which can be found between cerebral cortical excitability parameters with some psychological factors in pediatric age is very interesting, and it can be interesting also from a theoretical point of view. I think that the further studies are needed to confirm that early structural changes of the brain exist in a patient with migraine, supporting the idea that migraine is really a disease. And I would like to conclude with a sentence wrote by Marina De Tommaso in this editorial article some years ago. Childhood migraine is the best model for the study the pathophysiology of this disease, because many factors may occur during the life, and there are environmental influences, there are comorbidities, but there are also the action of drugs used for migraine, drugs used for other conditions. Thus, so my suggestion is, if you want to better understand migraine, study children. Thank you for your attention. Okay, we have finished. I hope that this was an interesting symposium for all of you, and so I hope that there can be some questions. I would like to thank all the participants, the speakers of the symposium, and of course the Italian Society of Psychophysiology and Cognitive Neurosciences, which endorsed the symposium. Thank you very much for your attention.
Okay, so what are the conclusions of this previous study? And really, if we can inhibit pain-related structures, we probably have a large inhibition of cortex. In fact, in our previous study, we demonstrated that on realistic models of magnetic resonance in migraine with aura, cortical spreading depression diffuse across the brain cortex. And it also involves the peripheral-insular cortex, the cingulate, all the areas that are just responsible for pain processing. So our hypothesis could be that though CGRP acts and CGRP monoclonal antibodies acts on peripheral afferents, they could inhibit, tonic inhibit a large part of cortex. And this is also in agreement with the animal evidence about an effect, a slowing effect on cortical spreading depression progression. So studies are going on because we need to understand, to better understand how this type of peripheral modulation could induce also a change in the history of central nervous system diseases, migraine. And I think that this type of model could be applying also to other diseases of the brain. So I wish to thank you very much for your attention.